Uh, all right, so now we can't swear because it's all, this is all official now.
A lot of
So,
pressure.
good afternoon, or morning, everybody. It is the September 28th. The summer flew by, and we are uh, doing our end of month fireside chat. So that's every month. South Dakota Healthcare Coalition tries to bring a guest on board and talk about a hot topic in healthcare and healthcare emergency management. And this month we have old school Heather Kroeker, who goes back to historically. I'll let her explain where she's been before and after her interactions at Sanford with me. But Heather was one of my original team members on Sanford. She was the emergency manager at Sanford Fargo. And so we were the team of myself, Heather, Matt Van Vooris, and a revolving cast of interns. And Heather was part of the team that deployed down to Hurricane Dorian in Florida, and participated in the madness. The 6 or 7 days or along down, we were down there madness, and Heather got to actually work the receiving facility, where Matt and I worked the sending facilities. And so she was on the receiving end of 200 and some odd long-term care residents, senior living, and assisted living and skilled nursing people. So right after that, she left and took another job. After months of therapy, Heather moved on.
Broke up the dream team. Yep.
Yeah, broke up the dream team, and moved on. So I'm going to let Heather talk a little bit about her background, talk about where what she's been doing, and then we're going to talk a little bit about workplace violence. And Heather, this is just kind of a chat. Forget that there's 2,000 people listening, and we'll just go from there.
All right, cool. Yeah, thanks, Greg. So before my time at Sanford with the Dream Team, doing emergency management, I got my degree in emergency management, my bachelor's, and then also got my master's in public health. So right off the bat, I kind of started off working at a public health unit, small town, North Dakota. So that was a really unique experience to kind of get some good hands-on training in public health, which then came into play during COVID. So then from there, started working at Sanford with Greg and his team. So had a great time there. And then from then, I think most of you probably, since you're kind of in the healthcare realm, heard of the shooting that happened in Buffalo, Minnesota. So that happened at a clinic there. One of my friends and coworkers that I'd worked previously with had called me after that incident and kind of stole me away from Greg and recruited me down there. So I think from there, I've been working at Alina, really cool experience to transition a little bit out of the core EM space, but also kind of jump into that employee safety. Like, how are we going to keep employees safe? Because, after that incident, I think there was a lot of work that needed to be done. And you really kind of have to have that EM lens, but also kind of a little bit of employee safety, and have some EMS background, just a little bit of everything. And so, Greg had encouraged Matt and I to actually go through, get our EMT certifications. And so I think that kind of came into play a little bit too. So I think just having all that knowledge and experience is where I'm at today. So kind of in that EM, also environmental health and safety and employee safety sector.
And interestingly, the coalition has just recently started spotlighting women in emergency management. So we had we had Shannon Saunders in here last time talking about some of the barriers that women face, and we started a and you can talk about that if you have any stories related to barriers that you faced as a woman in emergency management. We know that it is still a male-dominated sport, by about an 80 to 20% deficit. And the Healthcare Coalition here is working on a diversity and disaster partnership, which is growing pretty quickly. But it also includes, the recognition of women in emergency management and trying to level the playing field in the emergency management realm. So here in, the South Dakota Healthcare Coalition has, I've not, crunched the numbers, but I think that we probably have an equal number of women and men in our coalition. And that's just a healthcare thing. But through national data and so on, we're seeing that there's a disparity there. So after you left and you went to Buffalo, so what happened? Tell us a little bit about the incident in Buffalo. And I want to get into later, I want to get into, the real workplace violence issues, but the incident in Buffalo was an anomaly. And in healthcare, we have daily workplace violence issues. So let's talk about the incident in Buffalo first. And when you went there, what did you learn? Like, what happened? What did you learn? And what were the conversations about changing practice and stuff like that?
Yeah. So essentially what happened was a man had walked into the clinic, fairly empty that day. There were a few people in the lobby, including a mom with twin babies and little baby carriers. So if you can imagine trying to get out in that situation with two clunky like baby carriers, no matter what training you have, it's not happening, right?
Thank you. I kind of feel like a Muppet.
So
I'll get that. I'll take
okay.
it. You go.
Yeah, and so he had a short conversation with the upfront, person checking him in, and essentially then had pulled out a weapon, and started shooting. So he did shoot at the people at the front desk, and the nurses that were up there. Of course, they tried to run behind them and close the door, but of course, the people that were right up there, checking him in, of course, didn't have anywhere to go, so they did hide under their desks. That wasn't the only thing. He also had bombs located around the facility that he did deploy. So there was that going on at the same time of him shooting. He was able to make it back into the clinic area, and was back there for a short amount of time, and then came forward back to the lobby. Of course, everyone in the lobby was trying to get out. And then at some point, the police did come, and he did kind of like cooperate with police at that point and leave with police. But it happened very shortly. We try, I don't know. So I think a lot of the conversations so that's the incident. That's kind of what happened. The clinic did shut down for a couple of months after that. Some conversations then that kind of started. Of course, I wasn't there right away in the beginning of it, the gaps and some of that stuff. But I think after that, there's a lot of talk of like, how can we, there's these small facilities, how do we keep them secure? But throughout all of that, somehow the conversation really shifted. And I think this is where we just really do need a lot of more attention on workplace violence, because even after a big incident like this, the conversation shifted from how do we protect our clinic workers and our workers, that are at these sites that don't have security, to how do we protect our big hospitals? How do we, what are we going to do to protect? Are we going to get extra security? What are we going to do? And unfortunately, there's still really no change that happened at our small clinic facilities where this incident actually took place. So I think there's just so much work to be done in this space. So I think some other things were like in these kind of like in this specific situation, how would someone like that alert police? Yeah, we've got like a panic button under the desk, but if that's who gets shot first, who's like going to hit the panic button? So I think there's just a lot of things to like work through and talk through in your facility. And again, it happened like in a blink of an eye. So it just really, really kind of unexpected. And what are you going to do about it? I don't know. I think there was a lot of conversations. And then who is supposed to respond to those incidents? We know who responds to hospital incidents. We've got security on site. But again, for those clinics that are out, standing outside of our hospitals, is it the hospital security that should be coming? Is it 911? Like, are we calling 911? Like, who is it that we're calling and who's going to get there first with the right support that we need? So I think just really making sure that our operations plans are very, very clear for staff. And I think at the end of the day, we kind of decided, let's just always call 911 first, no matter what. We'd rather just get the help we need there instead of relying on hospital security to come check it out and, you know, do their thing. Although that is a lot of the case, like what we want to do. But even if they're law enforcement trained hospital security, they still don't have all the backup that is needed in an active shooter situation.
Were you
Did I
working?
miss anything?
Were you
Go ahead.
working at Sanford when we had the incident in Aberdeen? Were you still there?
I think I started right before, or I started right after that happened. I think I was interviewing you like the day it happened or something.
Oh, that's right. We were interviewing for the position.
Yeah.
I was on the phone doing an interview when I got the call, and I was like, I just checked because I like as you were talking, that story came to me, that whole incident, and I checked to see if Jason Herbeck was on. So Jason will enjoy this part. We were doing interviews for this position, and I was on the phone, and I get a call from Jason Herbeck on my cell phone, and I hit the "I'm on a call, can I call you later" on my iPhone thing, and Jason's like, no, you need to talk to me now. And so I call him, and he's running down the hall, and he's like, we have a shooter, and he's a little out of breath, and so I got up, I got a little bit of information, I hung up on the guy I was interviewing, and I ran down the hall to Cindy Baldwin's office, and she was on a call. And I opened her door, and she's like, "I'm on a call." I'm like, "Hang up. We have an active shooter." So what was interesting about that event was what was occurring there as the news spread of that. Luckily, it wasn't actually a shooting event. All indicators said that it was in the initial event, but in Aberdeen that day, there was like a meeting of law enforcement. And from what I was explained to me, like there was just like massive amounts of police cars from like all over the place just converged upon the hospital. And one of the things that I think we went up, we flew, actually, that was what broke my fear of flying because they flew me up there. But we went up, and Matt and I went back up the Monday after to do some after action work. And the impact on staff is incredible when you have something like that. Now, in that particular event, there was no, like, there were people who were close to where the event was occurring that really thought their lives were in danger, and it impacted them heavily. Like we gave them some time, like it happened the week before, and we were back up on a Monday, and we gave them some time to recall and calm down. Then we started doing some staff interviews, and there was a lot of need for post-event counseling and so on. So I can't imagine that your staff did any better, especially when you had actual gunshot victims occurring in the clinic. How did that work out?
So I'll give you an answer, and then just let me know if this is what you were wanting to get out of this. But so there was one death, and then all of the victims were then transported. It's just a couple minutes away to the hospital. So EMS came, transported them to the hospital, and then of course a lot of them had to undergo surgery. Very scary. Lives were hanging in the balance. And I think that's another piece to it. There was so much love and support for the clinic and the clinic staff, and so much understanding for them. They just went through something horrible. They lost a coworker. But what about our ED staff that treated them? This is a small town. Everybody knows everyone. They know the victims. They work with the victims. It could have been them. These nurses a lot of the time are hopping over to the clinic doing their own thing, or worked there for 5 years now. They're working here, right? A small town. That's just how it works. So just that thought of it could have been me. Having to operate on your friends and coworkers. It was also really, really traumatizing and scary for those people that were there. Of course, they all came together and supported and saved lives that day. And again, everything worked out really good with transportation. That was all really quick and smooth. But just kind of that after support, I think was maybe lacking a little bit, for even just the hospital staff, because it could have been them.
That's an ongoing theme in in emergency response and healthcare. I think overall, though, I mean, going back to 9/11, the post event mental health support was basically absent. And in a lot of events, what we try to do, I've been having a lot of conversations with my friend Jean LeBlanc, and she's spoken at our conference before. And I think I might do a fireside chat with her. But we've been talking about the word resilience when it comes to mental health. And there is a stigma attached to healthcare people, first responders, and so on, that we are kind of above the impact of the emotional impact of things. And that stigma is slowly being erased. But there's this stigma out there that Jean brought to my attention. The utilization of the word resilience is, in some circles, not in mine, but in some circles, if you are emotionally impacted by something, you're considered not resilient. And I just looked at the American Nurses Association has a suicide/resilience program going on. And I'm trying to look into it more because I really want to dig into the definition of what resilience is. But one of the things that happens during COVID, I activated or told my leadership team we're going to have 3 issues. We're going to have the war without weapons, like we're going to get attacked by this, whatever this is. Then we're going to have the weapons are going to come in. We're going to have antivirals and vaccines and all of that. It's going to be our second bump. And then the third bump is one that we're probably going to forget about, is that when it goes away, and the wave drops and the patient surge goes away, we're going to think that our staff is okay because the surge is over. And that's a mistake. Because if we look at March 10th as the activation day, let's say right around that week of March, everybody in the country was like, spinning up. If we look at that as the date life changed for a whole bunch of people, we just don't go back to who we were, 2 years earlier. Like, these are people who are trained to save lives, and they're losing lives, to a disease that they don't know a lot about, and they're in fear of their own lives. What do you think? And this is just an opinion-based question. What do you think we need to do, even from a healthcare coalition, but as healthcare professionals, to increase the awareness that mental health issues are real, that it's okay to use the words of Chris Sani from Wakefield, Brunswick, it's okay to not be okay. And how do we, was there any initiative that you were aware of, not necessarily related to Buffalo, but in Minnesota, for example, to do healthcare or behavioral health interventions? I have been thinking about like a behavioral health response team for the coalition and stuff like that. What is your thoughts on stuff like that? Is there any initiatives going on that you're aware of?
Yeah, with this last legislative session in Minnesota, they passed, whatever, saying, that like violence prevention is going to be something that we can like focus on and put money toward healthcare. And so that's changed things a little bit in this past, I don't know, 6 months or so. We've been like putting more effort toward it, but I don't think anyone really like knows what the answer is. And I think that's what's hard, is you have so many conflicting like ideas, and some ideas are like boots on the ground ideas, and some ideas are really like prevention focused. And so then you kind of have the clash of like the boots on the ground ideas, like those are things that we're going to see right away. And that's what our leaders like to see, because we see action. Like, we can give these people counseling sessions, we can offer more support, we can, but how do we prevent like things from ever actually like happening? How can we give like support to our staff to like build that mentally strong base? Like, it's ongoing, right? Whether it's work or home related, like we're always dealing with something mentally. And so it's okay to not be okay. And so what are we offering people just on the daily? Why do we have to wait for an incident to happen to like offer them support? I think a lot of like organizations offer kind of like a standard 6 sessions or whatever, counseling, but it's not necessarily convenient. It's, I mean, 6 sessions. You don't want to use it and then need it later, right? So then usually people just don't use it. I don't know. I think there could just be a lot more dollars put toward, yeah, mental health, and then just understanding that everyone has different needs. And I really struggle when, you claim a disability. So you have autism or you're neurodivergent in some way. We're claiming that before we start working. We're filling out a form saying, yeah, I don't have this, even though you might. You're just going to say you don't, so you get the job or whatever, right? So it's just right when we're getting hired, we're already saying like it's not okay to not be okay. So I think even just that whole process, and especially in healthcare, like nobody I don't know, it's just there's such a stigma around it. And there's a lot of things that you can't do if you're diagnosed with certain things. So even just like if you break your arm, you can't work on the floor anymore. So we try and like hide things a lot of the times because we want to keep our jobs and we want to do it. So I think that's 100% true for mental health. And I don't know, I think there's a lot of work, but I think I don't know exactly what it is.
And the impacts are multifaceted. It's not just patient caregivers. When you're pulling staff in and your support staff, like you have people who have home issues, like you mentioned, that stuff that's going on at home that gets disrupted because they're working extra hours or they're working shifts that aren't necessarily theirs. And we look at operational periods and things like that. And the impact can be something we haven't even thought of, and I think that you're right. I think that, that do you have a disability question when you apply for a job and you have to sign that, it's not like it's an optional, like, are you white, black, Native American, that's an optional one. And, this one says, it's done based on the ADA, and that they can't discriminate. But yet, if they can't discriminate, then why ask the question? Because people will not disclose that. And so it's a very interesting point that you make. I want to steer back for a minute to workplace violence because I want to continue to have this behavioral health conversation, but I wanted to make a point and get your opinion on that. I went up to Fargo once to present to the board, the Sanford Board of Directors, and I had 10 minutes. Me, I was like, Greg, you have 10 minutes. I had 10 minutes to talk about workplace violence. They wanted to really talk about active shooters because I believe there was a shooting somewhere. I'm not sure if it was the Buffalo shooting, but there was a shooting somewhere close by. By close by, I mean within the tri-state area. And they wanted to know what we were doing to protect against armed intruders. So, the first thing that they were like, how are you, Greg, working to make our facilities active shooter safe? And I'm like, well, first here, I'm not going to ever lie to you. And everyone here knows this. If somebody wants to walk into a building with a firearm, they're going to do it. And we're not going to be able to stop them. So our line of defense is, run, hide, fight, Alice training, getting people to be more aware of, don't run toward the sound, run away from the sound, doing lockdowns, finding lockdowns, like the generic, and there's really hasn't been much of an evolution in, here's what you do when someone's shooting, run and duck is basically what it is. And that's been that process since guns have been invented, and you just have to wait. But if you remove targets from the area, you reduce the number of casualties. But I said, the bigger picture is there was a New England Journal study that's probably still the most hallmark study of armed intruder events, that basically shows that armed intruder events in hospitals are very rare. They're usually domestic. It's not something that somebody shoots up a concert or shoots up a mall or or a school. Hospitals have really not seen, like, just about every incident is related to a domestic dispute or something like that. Not downplaying them, but the bigger problem, and the data that I brought from the 4 regions, was that over 90% of healthcare staff that work in emergency rooms and clinics have been some victim of physical assault or abuse, and that's the real workplace violence problem. And we can get all hyped up on the next big Vogue thing, and you've heard me say, I'm sure, dozens of times that emergency management is like the fashion industry. If we start wearing mini skirts in France, they start wearing them in New York. So if we have a swarm attack in Mumbai, India, we're starting to plan for swarm attacks. If we have an armed intruder somewhere, we're going to plan for a year for armed intruder. And then we put the real stuff on the side because it happens every day, and we normalize it. What do you think? What changes that? I'm going to just throw you on the spot. What changes that for how do we better protect our ER staff? And I know we have security, but we have probably 90% of the people on this call right now are COP facilities that don't have a security officer. The maintenance guy is the security officer, the environmental service guy is security officer. How do we change that practice? How do we, what's the paradigm shift?
Yeah, I mean, I think for one, we need to start, like anyone in healthcare, we need to start advocating for ourselves. I think we don't often advocate for ourselves. So those ER staff, they're just getting subjected to it. Maybe some manager, somebody, or a different organization didn't do something about what happened, not to their liking or not what they thought. And so then now they just are quiet and they just stick their head down, do their work. They get, assaulted, and they just continue on their day. They'll file the report. We actually, honestly, the biggest hurdle that I learned working in safety, employee safety specifically, is that like looking at reporting, people aren't even reporting it. We see reports of assaults, maybe on meds or just a little bit less common. But people in the ED almost never are reporting anything anymore. Or they might say something to like security and like, hey, this has happened, but security, it's not their responsibility to now report it to occupational health. So I think just one is advocating for ourselves, because then that's going to provide data. Without data, we can't do a lot of work, right? Like everyone wants to see data, like prove to me that this is happening, prove to me that it's affecting. So I think that's one, advocate for ourselves, report when it's happening. Don't be afraid to press charges. That's something that's becoming more common now, but still, like, a lot of folks don't want to do it because, again, these are their patients. They see them all the time. They might not hurt them one day, but they might hurt them the next day. And again, in small towns, it's the same. You work with them, you live with them in the community. So it's really hard to press charges, but Wisconsin had a big push for that this last year. And so now Minnesota's kind of picking up on that a bit. So just, press charges. And if you just keep doing it and doing it and doing it against the same folks, eventually they're going to do something about it, right? So I think, like, yeah, it's scary, but I think that's where we need to come in, especially in emergency management and security and whatever else, like how can we support those folks then that were assaulted? Because I think that's another like key part is how do we support? If we support to a level that makes the employee that was just assaulted feel like comfy, feel safe, feel like they're at home and their team got their back, we get to that point, they're not leaving, they're not quitting, they're not finding a new profession. They're going to be more like apt to report in the future. So I think we're missing that whole support thing after an incident happens. So I think increasing the support they get, and what does that look like? I don't know exactly what it looks like. Some ideas that I was tossing around a little bit are like after an assault happens, a lot of times people, they'll get their counseling, they'll report it, but then they still have to go back and work the floor like 3 days later. So 3 days is not enough to get over something like that. But of course people do still want to like make money and they still want to keep their jobs. So like, what can we do? Can we have like a team? Can we have like someone that's not security, but some like just a friend outside the door as they start like, working with patients again, because they're going to be scared. Like no matter who it is, they're scared. So who can we have like on backup? Just someone right outside the door, someone just right within ear distance, who's just that's just focusing on them while they're with that patient so that they can get comfortable again. But more importantly, just are we asking staff, what do they need? because in my experience, when we do ask, we don't want to provide what they need because we don't want to give this staff special treatment or this person special treatment. We've got to make sure it's fair for everyone. Well, unfortunately, not everybody needs the same support. And so we need to start looking at it from not just this like one support option for everyone. And just like emergencies, right? Like, yeah, we kind of have, we can plan to a point how to handle every single emergency, but we use that all hazards approach, knowing that we still have to tweak it. We still have to tweak every incident, right? And so we need to do that for people too. We need to have some grace and let them get different support if they need different support. Some people need more days off. Other people need, just a buddy in the room with them or outside with them. I mean, there's just different things that people need. So I think just really recognizing that is a place to start.
The normalization and the lack of reporting is a long-term thing. And I know there's EMS people on the call, and I don't know how many times when I was working in the ambulance as a paramedic, we would get into fights in the back of the ambulance and, get assaulted, and people would throw stuff at us, and we'd have giant tussles, and, we would get them on the stretcher and get them in the ER and then go for coffee, and you'd have a cut on your head or a cut on your arm, and, you clean the blood out of the back of your ambulance and you just keep going. And, you're right. Nobody ever, there were occasions where we called the police in incidents, but most of the time we were able to manage it on our own and just get the patient to the hospital. And you write it off to, mental health issues and things like that. For example, I was just talking to somebody when I worked in New York City. I had a homeless guy. He's a young kid. He was probably about 25, who every time he saw me, he wanted to fight me. He would stand in front of the hospital and he always wanted to fight me. And we used to joke around, like when he was sober, he was like the nicest guy in the world. And when he was drunk, he would like come up and try swinging at me and square off with me. And I used to tell him all the time, when HBO pays us each $3 million to fight, then I'll fight you. And I was always able to bypass this issue. But, other times, and every EMS person has experienced this, the back of the ambulances can be a very, very hazardous place when you have violent people, and we do normalize it. And I think that's part of the problem, is that we just consider that it's part of the job. And I think that's why the numbers stay high. I know that some hospitals fire patients now. They call it firing patients. And they just, you're not a patient here anymore. We're not going to take you as a patient. You're going to have to go somewhere else. And, and even the, it all really depends on, the condition of the patient and what kind of services they need. But we can't write off the danger to our staff because, we say, well, they're a psych patient, or they're, or they, their blood sugar was down. I have had many wrestling matches with people who have low blood sugar to try to get sugar in them, and so on. But it's not okay though to allow that. And I think that that's part of the big message is, a drive to say, it's not okay to get assaulted. It's not part of the job. And it's not acceptable. And, there's a code of conduct as a patient in our emergency rooms. And I think we're seeing a little bit of a transition with that. So let me ask you another question. What do you think the interplay is between in healthcare between emergency managers and safety and security people? Do you think that there's knowing the experiences that we've had, do you think that there is a quality connection between the three divisions? Do you think that they're working generically close enough together? Because it's really not the emergency manager's job to provide security to the ER staff, but it is our job to do the research and try to get the planning. So is it something that interacts, or is it something that we're up against a wall and like, well, that's security's job, that's safety's job, that's not emergency management jobs? What has been your experience in that overall career-wise?
Yeah, I'd say overall, I mean, it's kind of varied, but it's very much like, nope, that's not my realm. And so the kind of the three sectors of like safety, employee safety, environmental safety, and security, and then EM are fairly separate. I think every once in a while you get like a cool connection with someone, and you can go from there. But like in terms of like, you know, we all get along personally, but in terms of the work, it's like, you know, no one necessarily wants to take, you know, responsibility, and rightly so, in the fact that like this stuff is serious, right? Like people can die. And so I think that's part of the issue is like, we don't always get paid enough to be like making these calls, right? And I think there's a lot of pressure on emergency managers and safety folks and security to be like making the call, like I'm gonna make the call to keep this area safe, or like in this situation I think this is what happens. Yes, you're the subject matter expert, but like you're also getting paid $15 an hour or something, right, as like a security officer. And so at the end of the day, like it all comes down to education, training, and really, like, are we, what is our realm? I don't know. I don't think that any of us really know exactly what our realm, like where it ends and begins is. And I think it's a struggle. And I think if it wasn't such a serious topic, I think it would be less of a struggle. I think there would be much more interplay. But that's just my experience anyway. I don't know how to necessarily like fix that, but I don't have security officer training. I don't have that. So, I mean, I shouldn't be doing their job and I shouldn't be recommending certain things, but I think we do, you know, at the same time need to drill together, need to come up with our plans together. I think there's just a lot of situations where we do like get halfway through a plan and, you know, this is how we're going to respond to it. And then, yeah, one of those parties comes in and they're like, no, this isn't going to work. So I think I don't know. And then it's like, well, we just did all this work. I don't know what the answer is. I think just getting involved in the beginning. And then my other kind of thing is, yeah, we think of these three sectors like playing together, but I think we all, at least in my experience, we oftentimes forget to like grab the people that are actually like involved in it, or like the people that this actually affects, and have them in the planning. We pull in managers a lot. We're not pulling in frontline staff as much as we should. I get it, they're working the floor, but we also are planning a response, you know, for their area. They're the ones that are going to have to respond. I can guarantee you this, you know, front staff person that was checking in the patient, you know, in the shooting was not in charge, like in the works of the organization's you know, active shooter planning. So like, are we just involving those people in, and then after like incidents happen, like, are we involving them then? You know, they lived through it. How are we involving them in the planning for future? We do quick, you know, sessions and like get the gaps and stuff, but then they're now the subject matter expert. They've got more experience than I do. So now they should be like, you know, like, I think that's a cool opportunity for organizations to like put these people up, and really, you know, and like reward them, pay them appropriately for now being a subject matter expert in this area. I mean, I don't know. Not saying that everyone wants to do it, but I just think there's a lot of opportunity there. But anyway, long answer to, I think that, yeah, very separate between the little sectors in healthcare.
Yeah, and there tends to be turf wars. Well, it's been my experience that there, and it wasn't. It's at every facility I've ever been at. There tends to be turf wars between here and there, and like, oh well, this is your, like, if they don't want to do it, it's like your job, and if you know, and if you try to do something that's their job, it's like, you know, and they're really, you know, there really shouldn't be. And you know, an interesting. I started reading NFPA 1660 because, you know, why not, right? And you know, and they're starting, you know, the NFPA is starting to pull in some life safety code into the emergency management standard. I don't want to misspeak because I think I saw it in there, but generators and things like that are now part of, and you know, it's really expanded the role of emergency management. And I think that new document is going to really make change for the CMS rule as well as Joint Commission. You know, they all kind of follow suit. One follows the other, and you know, so, and Joint Commission doesn't change until NFPA 101 changes. You know, and they put, you know, the NFPA puts out the newest version, and you know, and that was not always the case, but now there's, you know, the question now arises is, where does 1660 fit in? For us, it's a driving force because it is the foundation for CMS and then the Joint Commission. But you know, where does that all fit in, as far as you know, even the hospital preparedness program? You know, there are there are components of the HPP competencies that talk about behavioral health. But they're, there's like here, facility, behavioral health services are provided. And it doesn't really get into detail. And that's what we've been looking at. There are a lot of gaps in the HPP program. Like the requirement for decon kind of drifted away. And now it's, hospitals think, well, now it's not a requirement for HPP, so we don't have to do it anymore. But if you look at the OSHA requirement, it's there, and it's our job as emergency managers is to know, all right, this one impacts us here and this one impacts us there. And, it's not just one standard. You have to bring all the standards in. And I just wonder if it becomes our job somewhere along the line to look at the standards for workplace violence and behavioral health, because I think they're connected. I think behavioral health issues, for the most part, cause workplace violence. And I think workplace violence and response creates behavioral health crisis in our people. So there's this kind of everyone's in the smoke kind of thing. And I feel like it's somewhere along the line, it's our work to do the research and bring it to the front. We don't necessarily have to do the work, but maybe that's what it is. Maybe it's our work to say, hey, listen, this is happening, these trends are occurring. And bring it to the forefront, which brings us to the role of C-suite. What do you think? I just did a presentation in Sioux Falls about emergency management, of course, and I was talking about C-suite's role, and we talked about the 3 bumps of COVID, and how we strive so hard to get back to normal. That we forget to clean up some of the pieces and the glass gets swept, into the corner or under the rug or whatever. And that glass, ultimately is our people. What do you think our role is in coordinating with C-suite to ensure that research, that knowledge base gets to leadership, and we can do something more impactful? Has it been your experience that C-suite has been supportive? Or are they more, we got to get back to normal as quickly as possible, resume normal operations and get back to the regular business, which isn't a bad thing. It just, I think the return to regular business includes healthy staff.
Yeah, I think just coming off any incident, they're very supportive. And, during an incident like COVID, they're like, okay, yep, we're going to need to do these things. But I think if you're trying to come to leadership, just like, let's say you're seeing lots of trends in workplace violence and you've done the research, right? Because you might realize that there's a problem during an incident or right after an incident like that. That's our work, right? We discover the stuff after it happens. We're like, okay, these are our gaps. Well, now it's already been a week. It's been 2 weeks and they don't care. They're back to normal business. And so now getting their attention again and to care after the incident, I have found very, very difficult. And I think it's just because, well, things are going smooth again. Everyone's back to work. We're okay. Like, yeah, I hear you. But that's no longer their job anymore. Like now they're kind of like off the incident. They're going back to their regular duties too. And they've got packed schedules and things that they need to do. And so I think just finding a way to like have that respect right up the bat, and let them know like emergency management is not only here when there's something going on, but like we need to have your ear always, because we're going to see trends, we're going to notice things, we're going to be paying attention to what's going on all the time across the nation. Like that's what you're paying us to do. Listen to us when we come to you and let us start projects or whatever. So I think there's just like that connection that needs to be made. And I think just best to do it like right when you start the job, be like, hey, this is the expectation. Once you've been there for a hot minute, I think it is harder. So I think, anytime someone's starting a new job, especially emergency management, just make that expectation known with them right off the bat. And I feel like that's been more successful with me. But I think it's a challenge across the board.
And I think that I think you're right. I think that the in the short term of an event, the emergency manager it's kind of like and you've heard me say a million times, the mop in the closet thing. And I presented that multiple times. And it still seems to work, and I don't know how to change that stigma. Utilizing the term emergency and disaster might be one thing. Like, and I've struggled with the word crisis management, because C-suite folks, they are crisis managers. They manage crisis all day long. It doesn't have to be a disaster. It's financial crisis, this crisis, a shortages of supplies and resources, and IV solutions, whatever it is. And how do we fix that? So I think that the crisis management skills are there. But I think in a lot of cases, not all cases, but in a lot of cases, the connection between C-suite and emergency management is there's 3 or 4 layers of leadership between you and the people that actually need to hear you. And if you have a boss that doesn't bring that, you have to worry about providing a report and saying, here's what we need to do, and it needs to get to the presidents, or the CEO. And if your boss believes in you and brings it to their boss, you have to now rely on their boss to believe in it and go and say, well, I have 16 other things to talk about, so this has got to wait. And that happens frequently. So it may not be, I think it's a combination. I think it's sometimes the prioritization of well, that's not happening now. So therefore we don't have to worry about it. That mindset is a substantial mindset. And the downside, and this is just my opinion, and of course I believe it's right. The downside is, even the emergency managers are not utilized enough. And or the message I delivered at Sadaho this week was, you should have a full-time EM. It shouldn't be your lab person, and it shouldn't be your quality person, and it shouldn't be your environmental services person or your maintenance guy. And you say, okay, you're officially here, have a patch, you're an emergency manager now, and call Heather or call Greg or call Matt, and they'll tell you exactly what you need to know about being an emergency manager, because that is an immediate recipe for failure, because that person doesn't know all of the trending that is occurring in the United States. They don't know the sport. They don't know what it is that is there. And it's a short-sighted practice, because the cost of failure in disaster is way higher than paying somebody $60,000 a year to be an emergency manager, like a livable salary. And I thought after 9/11 it was going to change, and it didn't. I thought after Ebola it was going to change, and H1N1 it was going to change, and I thought for sure after COVID it was going to change. But there's a trend right now in getting rid of your hospital emergency managers with cuts because of all the losses for COVID. Final question. We have 7 minutes. Because it is kind of related to the topic. It's kind of related to everything. How do we change that paradigm? How do we get the healthcare leadership realm to understand the value? Like risk management, for example, is a big thing. Like the risk managers, there's tons of risk managers, and risk works every day. And is it just that we start presenting ourselves as another type of risk manager, which is what we are? We are risk managers. We identify risk, we mitigate risk, we different kinds of risk, potential risks and disasters and so on. How do we change the paradigm on that? I'm asking you for all the answers today, because
Yeah, I've got them. No, I'm just kidding. I think just something that I've learned in the last month or two here, as I'm kind of rebranding myself a little bit. At the end of the day, healthcare is a business. All businesses are business. I mean, everything's a business everywhere you look. So how do we kind of appeal to the business side? I am finding that you say that you work in business continuity. Everyone wants to have a piece of what you have. Everyone wants to know what's going on, because it has part of it has the word business in it, and a lot of people know business continuity. You're going to keep the business afloat. You're going to keep it running. At the end of the day, yeah, it's emergency management. You're doing you're pulling in some other things. You're looking at business impact analysis, kind of some of those other other things too, but like I don't know, to rebrand and rename, a whole profession is silly. We're not going to do that, but I think like we need to appeal, like really appeal to those leaders, like that we're keeping your business running at the end of the day, right? There's something that goes down at the mall, like a shooting that goes down at the mall, or like everyone gets COVID from the mall, like no one's going to that mall anymore. The mall is done. Like, right. I mean, we already see that, like like malls, who goes to a mall because it's just so much easier, convenient, to go and shop online. So I think like how like we need to maybe change the marketing of our profession a little bit, less of a like I'm a first responder, I'm a previous like cop, and like how like here's me and I'm going to keep your business running like no matter what, and we're going to work with IT. We do that anyway. We're going to like for cyber attacks, like we're going to do these things to keep your business running. And like this is what we're foreseeing in the future, right? Like when you look at your stock options, you want to see if your stock's trending down and you want to get out of that potentially, or you want to be in it for the long haul. And so I think you want to always have emergency managers on there for the long haul, but also if things are trending down, like let's change a little bit. The emergency man, like we're here to help. So I don't know. I think that's just what I've noticed in the past month or two. Just really like playing into the business side of it, and less of the disaster emergency side of it. Just in like the lingo and the language that we say. Not the perfect answer, but just something I'm noticing anyway.
Well, and I think that that's I think that that's a start. And it's funny you said appeal to. I presented I created this thing called the appeal process for healthcare emergency managers to work closer with their CEOs. And we did it in Scottsdale, and then we did a webinar on it. But it's it's a start to try to say, hi, I'm here. This is what we do. I'm not the maintenance guy. I'm a specially trained person who has I try to define it like, if you could say, I'm a neurosurgeon or I'm an OBGYN. The OBGYN is not a neurosurgeon, nor is the maintenance guy an emergency manager. And without looking over at the participant list, I know that Matt also has a very strong opinion of that. And I think you made a good point. Emergency management was originally flooded with firefighters, EMS folks, and retired cops who wanted to get out of that business and come into the sexy new realm of emergency management after 9/11. And it created a stigma that we're still trying to overcome, in the sense that this is a profession, it's a discipline. There's specific academic education for it. There's certifications coming up in it now, and so on. So the change, while it's going to take some time, where you have people like yourself who come into the realm academically educated with the foundational knowledge, and all the tools, and get better and better through experience, versus all the people who have the experience, from 20 years ago, and then come in and say, well, I know everything that I need to know, and I don't need to change because I already have the job, kind of thing. So I think one of the things is that, as the age demographic of emergency managers changes to younger people, and all those older folks start retiring and move out of the realm, I think that you'll start seeing a little bit of a change in the profession. But I think we have a long way to go. And I think that, there's still a stigma with EMS providers, like, they're still being called ambulance drivers, 100 years after the fact, and
Yeah.
it's like one of the things that irritate EMS people, or the disaster person. Who's the disaster person? Like, the job is just as important as any other job in healthcare, specifically when you have something big going down, when you're the one sitting in the command center looking around at everybody, trying to figure everything out, and you're like, all right, you did this and you did this and you did this and you did this, and here's what the plan is. This is why we wrote the plan. This is why we drill. This is why everything comes together at the end. So I think that we just need to keep plugging away at the profession, and keep moving. And when our voices get heard, we can make some significant change, in planning for workplace violence events, and in planning for behavioral health, and in providing, you know, services for our people. Like we serve the hospital who serves the people. We serve healthcare, and we make sure that the motor is always running. I always say we're the biggest gear in the watch, and all the other gears in disaster, all the other gears kind of rotate around us. But if one of those gears isn't working, the watch doesn't work, and it always comes back on us in disaster. So, you know, we have a lot to do with it, but we don't always have the amount of say related to the amount of responsibility. And I think that we just need to continue to work toward that. So anyway, final comments?
I don't really have any other than, I mean, this was fun. Thanks, Greg. Happy to do it again anytime. It was good to see your face. And yeah, just hopefully everyone is charged with some workplace violence, you know, looking at it through a different lens after today.
Well, thank you very much for taking time out of your day. Congratulations on your engagement, by the way.
Yeah, thank you.
And it was a great picture. And I was glad that you shared that with me. So thank you very much. And this will be recorded. And let's stay in touch, and we'll just keep, we'll keep plugging away at, we're going to have to bring you in for Sioux Falls for a reunion one of these days.
Yeah.
If you're ever in town, just let us know, and we'll go out to lunch or something. Okay. Well, thank you very much. I'm going to stop.